semi-alive.
And everywhere else, no, I'm pretty sure we're live. I am. I can tell. I can't see right now. I can't see with the glasses. You ever have those days? You can see with them, can't see without them. I just want to poke myself in the eye. Bink. Oh, maybe now. Oh, look, they work better now.
Bifocals.
Mm-hmm. My butt. Okay, so we're just about ready to go live here on everything. Hi, Facebook. Hi, everyone else. And stand by. Let's see what we got here. Counting down.
Broadcasting live from the United States of America. You're listening to the Living Sexy Radio Network, playing the sexiest music on the planet.
It's time for Stages of Life Radio with Dr. David Klein. Have a medical question? Call 407-422-1212. That's 407-422-1212 or text 23680.
Just do it. Hey guys, we are live and ready to play radio. It's true. Stages of Life Radio, Melissa Fox, hello, hosting, helping out Dr. David Klein with all that is radio parts. I mean, the rest he knows. Seriously, the rest he knows.
I'll handle everything but the knobs.
I'll take care of that, yeah. I got the knobs and the faders and the switches. But really, my back hurts. I got some pain. No, I do. Can we talk about pain today?
I think we will. Let's talk a little bit about chronic pain, acute pain.
Chronic pain, acute pain.
Maybe not so acute.
Oh.
Not so acute pain.
Okay, not so acute pain. All right, and we'll also take your calls and text. Go ahead and get the text line hopping if you would. 23680. Again, the text line is 23680. Give us the information that you need us to have in order to help answer your question properly. So what do I do about pain?
Well, first thing you need to do, and first thing you need to understand is that pain is not a disease. It's not really a diagnosis, although there are some technical terms that we'll use for it. But it's really a description.
Oh.
It's a description of a noxious stimulus. It's a description of the sensation that something's wrong or something is being damaged or that damage is continuing. So pain is a very, very interesting and important sensation. If we didn't have pain, okay, we would develop things called Charcot joints. So folks that have, let's say, tertiary syphilis, folks that have certain neurological illnesses, or they lose sensation of pain, they destroy their joints. So they have difficulty walking. Diabetes is one of these sorts of conditions where you don't feel things going on, infections, wounds, and whatnot. And eventually, if you're not very, very careful, you can lose bits and pieces of your anatomy sequentially. First a toe, then a half a foot, then a total foot, then below the knee, above the knee, and so on and so forth.
Wow.
So what's it all about? So why do we care about pain? Now, let's take headache as an example. Headache is a very, very common complaint in the general population. It's an extraordinarily important one. The amount of time lost from work is enormous. The amount of time lost from your personal life is just astounding, or can be. And the cost, the economic cost, can be staggering. Now, there's a lot of descriptors for a lot, mega amounts. So why do I care? Why should you care? And the answer is this: because the approach to pain should not be any different than the approach to any other medical problem that you have. This is the same argument that the psychiatrist had with depression and other sorts of mental illness. Well, we really shouldn't marginalize these people because they're really just like everybody else with a medical illness. Until you go try to read their medical records, and then you can't read them because, after all, they get special privileges. Well, with pain, not only do you not get special privileges, but you get put under a very, very special magnifying glass, because the medications that we're supposed to prescribe these days all have to go through a central prescription clearinghouse, sometimes known as a spyglass for the feds and the insurance companies and everybody else. So every prescription, just about every prescription you've had since 2008 has been registered on a national database. Now, for the opiates, for the other, let's say controlled substances, everything from the testosterone that you received, which is a Schedule 3, to the Ambien, which is like a Schedule 4, Lyrica, which is Schedule 5. But then things like OxyContin, but even that prescription marijuana you're supposed to get, all of this stuff gets registered on the PDMP. This is a national database. So like it or not, they know who you are. So why do you care? And you probably shouldn't, actually. It's one of these sorts of problems that we can make a big deal of and probably get a lot of press out of it, a lot of exposure, but it really isn't necessary. The fact of the matter is that the more data that's out on everybody, the less anybody can pay any attention to you. Think about it. In electronics, they call that a signal-to-noise ratio. So the more signal that you have relative to the noise, the easier it is to pick something up. But the more noise you have, the background nonsense, the raspiness, the static, the background traffic noises, dog noises, whatever it happens to be, whatever the case may be, that is going to distract you from the signal. The signal here is if you're in and amongst 200,000 people that are receiving treatment for something, they really can't single you out particularly effectively. So in other words, you're not that important.
Oh.
Okay, that's the essence of it. You're not important enough for them to really pay attention to you. Now, what is important about pain? Isn't the controlled substances that are sometimes necessary, and they're not actually always or even usually necessary. Just because you're being treated for chronic pain doesn't mean you're receiving any opiates at all. Most of my patients that I treat for pain do not receive opiates.
Good.
Well, think about it. That should make all the sense in the world. You're going to go, why do I want to go see this guy for if I'm not going to get pain medicines? Well, I'll tell you what. Okay, you're a roofer. Okay, and you just went ahead and made a mistake. Like that never happens. And so you have yourself a nail gun, okay, and it pops that nail right into your thigh. Now, I have got to tell you that sounds like it's something, and as an expert in pain, that probably hurts. So what is the best pain medication for that particular injury? And I ask this to patients frequently when they come and they want to know what I'm going to do for them. Well, what am I going to get? Am I going to get this? Am I going to get that? And I said, no. The most important medication there would be a pair of pliers. Okay, you remove the nail and the pain goes away. What do you know? There are pain problems that are exquisite that have nothing to do with being treated with opiates, opioids, or other sorts of pain relievers. A good example of that is just getting an eyelash in your eye.
Oh,
you are totally incapacitated. You're driving down the road. You get a grain of sand in your eye. You can't do anything until it's removed. It doesn't involve pain medications at all. Dental pain, great example. The most effective medications for dental pain are local anesthetics and non-steroidal anti-inflammatories. So you can give people heroin, and it's not going to make a great deal of difference. They're still going to hurt. So as an anesthesiologist, that's what I do. I've got 3 boards in anesthesia and 2 others. Okay, what I will tell you, okay, is that pain is a complex situation, and the most effective treatment of all is to find out what's causing it and fix it. And if that doesn't sound simplistic, then I don't know what else. But that is actually the hardest thing in the world to get people to do. So even something as basic, as easy, something you might think is easy as migraine, okay, is not. Because most people with migraine don't just have migraine. They also have trigeminal neuralgia. They may have whatever the trigger is for the migraine, which could be, let's just say there could be a sinus issue causing it. It could be depression causing, bruxism causing, pinch of the nerve called the auriculotemporal causing the migraine to trigger, or it could be something as benign as menstruation. Okay, which, by the way, if you're supposed to menstruate and you don't, that can be a much bigger problem.
What if you're not supposed to and you do?
That could be a big problem too. Yeah, lots of problems to have. We can't mention them all today. I don't think as much time as that's going to take. So the principal responsibility of the physician, it's not just the pain doc, but any physician at all, is to figure out what's hurting. Where is the pain coming from? So I had somebody last week, okay, who went in, ended up with a quote-unquote migraine type problem, which wasn't migraine. And we were going through trying to figure it out. Why didn't any of the migraine medications work? When they went through all the usuals, nothing put a dent in it. Until I asked her, I said, this usually happens after trauma. You see this sort of unilateral bruxism, gritting of the teeth. Were you ever damaged, received a hit or anything like that to the left side of your jaw? She goes, well, no. Why would I? I said, okay. Nothing like an elbow, nothing like a punch, right. Nothing like a tennis ball or a softball or a football. I said, any surgery to that area? No. Okay, fine. What about oral surgery? I said, because generally speaking, when people have this, they'll have dental pain along with it, and frequently they end up with root canals or two, finding nothing wrong, and they still have the pain.
Oh.
Which turned out to be what it was. We'll pick this one up in just a few minutes.
You know, Dr. David Klein takes new patients. Unlike some people, Medicare accepted.
Love Medicare patients. They're
open
great.
At 9 o'clock tomorrow morning. You can give them a call if you like. Here's the number, 407-679-3337. Or even easier, just go online, stagesoflifemedicalinstitute.com. We're going to take a quick break. Be right back. This is News Radio WFLA Orlando. Yay! This is part of the stuff that I'm actually learning, is setting up all this computer stuff remotely, not only for your show, but for Gator Basketball, for the streaming services.
Yeah.
All that's everything that I've been learning. For those of you that are out there wondering, what is going on? Well, actually, I'm just taking on more responsibilities, it seems.
A few more hours, what's it to you?
Really doesn't matter. Nah. I'd like a little more money, though, please. Hello?
How about a parking space? One with your name on
I
it.
have a parking space. It's called Visitor.
I love it.
Anyway, so anybody that's watching us online here, which there's a handful, if you've got any questions for the doc, this is your time to get them spoken. We got a couple of minutes here of commercials as we play on the radio, and during that time, we like to, giggle, laugh, or help out other folks who might be listening and looking at us. I know. It's not easy. Thank you.
Yeah. So we had some really interesting folks walk through the door this week, which is kind of why I wanted to talk about pain to begin with. What's it all about? It is the leading complaint that brings patients to see the doctor. Something hurts, headache, abdomen, foot, ear, toe. God knows, it could be any number of different things. It hurts when I pee. It hurts when I see. It's all kinds of things. What is it going to be? And so pain is not the province of any one particular kind of doctor. And that's really kind of a shame that in today's domestic medical situation, they've got it fractured almost to the point where if you're an orthopedic surgeon, you specialize in left hips. Now, not right hips or left shoulders. Or, it's absurd the way that this thing is going.
Sound kind of crazy.
Because if influences, let's say that you have a problem with your left foot, it's going to cause problems in the right knee, left hip, right shoulder, and left neck because of the way that your posture is going to change from the way you walk.
Any word on magic minerals?
You betcha. Yeah. The word is that they keep lying to me. So that the manufacturers that I've got lined out there are having a difficult time getting one of the pieces in that mix, and we can't run it through without it. So it doesn't make any sense. But that's really what's going on. So what I'm doing with magic minerals is not necessarily giving up, but I'm giving in. What we're doing is we're substituting down to basics, and which gets you about 80% of the way there. And then when magic minerals comes back in, we switch you back to that. Easy enough.
Facebook or any others, we are a radio station. We pay appropriate licensing fees, so please do not partially mute our video. Oh, that's so aggravating. I mean, it really is. Oh, boy.
So I have one quick announcement, okay, because we've had...
It's time.
There we go.
Welcome back to Stages of Life Radio. Sundays, 4 until 5 p.m. Melissa Fox hosting with Dr. David Klein, giving us all the medical information we can handle. The pickers, hoppers, and finger groovers are really loud today. I'm really excited. Wow. Okay, so we were talking about pain, and that it's an elusive word. It's an elusive thing, really.
Well, it is. Pain is what it is. Okay, it can be experienced in any number of different ways. Different cultures actually handle it differently. When I was at Duke in training, we were taught, okay, that certain cultures experienced anesthesia different than others. In other words, when you see these people come through, watch out. Okay, Lumbee Indians, Lumberton, North Carolina. That was a big deal up at Duke and at University of North Carolina because that was right down the interstate. The second one is folks with red hair. Now, that kind of can be a lot of different people, can it? And the third one was Filipinos. Now, go figure that one out. So these particular ethnic groups have a tendency to react funny to anesthetics, but coincidentally, they also react funny to pain. So why does that matter? Because if you're in one of those groups, you already know what I'm talking about. But your doctor may not. So be very, very aware and very careful. So pain is a complaint that is really crosses every age. You know, a kid coming in with a 2-year-old with an earache knows what pain is. But we'll forget about it very quickly. A sore throat is a different kind of pain. A headache, very, very different. Broken leg. How long does pain following a broken leg last? And the answer is it hurts when you do it. It may last an hour or two, and then it's pretty well under control once you get the cast on. So the most important pain medication you'll get for a broken leg is a cast or a splint. Same thing is true of a broken wrist. Same thing is true of a broken tooth, believe it or not. So what do you do? What are your options? Now, with regards to chronic pain, this very much is different from somebody who has an acute disease process. If you have chest pain because you have pneumonia, that's very, very different from somebody that had influenza and now has persistent anterior chest wall pain. Okay, Titsy Syndrome is what that's called, and it's a monoarticular arthritis, and you can treat it as such if you know what it is. So I had a patient came in who thought that her thyroid inflammation, which she has, was causing her throat to go sore. I'm looking at the blood work. There were no inflammatory markers that were at all elevated. Her thyroid was doing beautifully. Her vital signs were doing perfectly, and yet she had persistent thyroid quote-unquote pain. So what was causing her issue? And this is where it got interesting. You know, well, it hurts right in my thyroid gland. I examined the thyroid gland. Thyroid gland was fine, but the carotid artery was not. So you can have pain in arteries, believe it or not. It happens. This is called carotidemia. And what can cause that? In this case, it wasn't radiation therapy, but if you've ever had radiation therapy to the head or neck, which happens all the time for cancer, it can result in pain of certain of the spinal nerves and other structures. You have to treat that very, very differently, and it's infinitely treatable. Skinny women tend to get something called aortitis, very similar disease in the abdomen, but it doesn't come from radiation therapy. It comes from just the fact that you're slender and very mobile. Okay, so the artery itself gets stretched. You treat these things in a particular way. So if you treat the right thing, wouldn't you know it, the pain goes away. But giving somebody an opiate when an opiate is not necessary doesn't fix anything but gives you yet one more problem.
Yeah, that makes no sense, really.
So let's talk about a common issue, something that walks through my door on a daily basis. And I opened what may have been the first office-based pain center in the United States back in 1983. At that time, pain centers were all at university, and that's where I was supposed to stay on at Duke, right? You know, they made me an offer that I couldn't refuse, so I took it. At the last minute, they rescinded the offer, changed it, and thought that I wouldn't change my mind. And I decided, if you're going to mess with me now, you're going to mess with me worse in 5 or 10 years. So I went into private practice, and I've been happier ever since. So what walks through the door? Somebody comes in that made the judgment to get a laminectomy for their lower back, or a fusion after the laminectomy failed, or a second fusion after the first fusion failed, or whatever it happens to be, and they have mechanical low back pain. And what may keep these people just their heads screwed on, might be an opiate. Now, what is it about opiates? And, well, for starters, there's a stigma attached to them. Anybody who's on these things knows exactly what I'm talking about. There you are. You're a judge, you're a cop, you're a teacher, you're an accountant, you're a whatever. But every time you go to the pharmacy to get your medications, they look at you like you're dealing this on OBT. So, no. So the fact of the matter is that there is a stigma attached to it, in spite of the fact that we've tried very hard to remove stigmata from our medical treatments. In the pharmacy, yeah, you're out of luck. You know what I mean? That's the way it goes. So you go in there, you might as well expect to get that look. Or they may not have your medicines right away. Or you're a day early, heaven forbid, that you should go out of town. So what is it about opiates? What do they do? Well, they change the way the brain interprets pain, but it doesn't do anything about the stimulus itself that's causing it. More so is that people confuse that funny feeling that you get from them with the analgesia that you're hoping to get. So when you're going about getting your pain medications, and the way I treated pain patients 30 years ago is very different than it is now, because back in the day, they didn't come back and say, well, you can't use but so much of the opiates. You have to use less than this, that, or the other. The joke is we did. We tended to go and get by with much, much lower doses and did fine with it. The problem is that when you throw the baby out with the bathwater, you get exactly what you expect. So here it is. You've got yourself a pain medication that you think you need. Your doctor may think that you need it, and that's just the way it's going to be. And you think that you're going to get increases in dosage along with the consumer price index, because after all, doctor, I've been on this medicine for 3 years. When do I get a raise? No, talk to Social Security about that. Okay, they may or may not give you a raise, but we will not, because we're limited as to what we do. So you think you're done. You think you got nothing else to offer. You think that maybe, okay, you're stuck. Well, the long and short of it is most people that do pain work have never really been trained to do it. Or if they have, you need to look on the wall to see where. And you can deal with pain by understanding that the opiate receptors in the spine are not what you're treating with those oral opiates, are you? You know, you're working on the brain. So what do you do about dealing with the pain generators, which actually may be in the muscles alongside the spine, or they may be in the muscles of your knee, believe it or not. You know, I treat patients with low back pain, you know, by treating their knee. Okay, it's very interesting. There are syndromes where there are muscle issues. Sartorius is one that comes to mind quickly, which goes from your kneecap to your thigh, or they call it the PSIS, you know, the anterior iliac spine. And so what happens here is that particular muscle entraps a nerve called the saphenous. That will cause referred pain in your kidney area. So you can end up with back pain that's being caused by a knee issue. It happens all the time. Well, with kids, when they come in with knee pain, you look at the hip. Hip arthritis will cause knee pain in adults, and knee pain is caused by hip problems in pediatrics. These are two very, very well-recognized situations. So how do you piece this and parse this out? By examining your patient, figuring out what the heck's wrong, and then fixing the underlying problem. So I get a great deal of pressure from patients to figure out what's wrong, and I get a great deal of pleasure out of figuring it out, because most people that come through do not want to be on these medications. They want to get out from underneath it. Once you've done surgery to these areas, okay, then all bets tend to be off, because now all of a sudden you've got a situation that is forever altered. So I want you to imagine for a second that in your car, okay, now you have two front tires. They're of equal size. Now we're going to go ahead and we're going to change that around a little bit. We're going to take one of the struts, or let's say the shock absorber, and just kind of goober it up. We're going to take epoxy and we're going to fix that thing. We're going to just go ahead and firm it up so that it doesn't work. Now you have an uneven or asymmetric front end of your car, and you're going to know that unless you're working on a what do you call it, a dirt track where you're always turning to the left, you got a problem. And that's kind of what happens when you go ahead and do hip replacements, knee replacements, or spinal surgery, is it has a tendency to cause other issues, not only remote to it, but immediately adjacent to it. So it's incumbent upon the person that's treating you to work through these sorts of things. And, you know, and what do you do when you give somebody a pain medication? You think that's benign.
Well, I had a question here real quick about that. You mentioned knees. Chronic knee pain, right knee burning above the kneecap.
Okay. Is there any pain in the back that goes along with it? Mm-hmm. Yeah. Okay, that would be the question. Okay, there's a bursa that sits just over the knee. Mm-hmm. Okay, there's prepatellar bursa, which is a little bit lower, but there's a second one where the saphenous nerve or the sartorius approaches the kneecap. That thing will start to swell. So if you're sitting down and you look down at your knee, you'll notice that, in this case, the right knee is knobbier than the left side. I can about guarantee you that the sartorius tendinitis that you're looking at will cause knee pain, inner thigh pain. But what else could cause that?
Uh-oh.
There are things that can and will. And
We
we'll
will
pick that up in
find
a
out.
moment.
Yes, we will. You're listening to Stages of Life Radio on News Radio WFLA Orlando. Dr. Klein's office open Monday morning, bright and early. You can call him 407-679-3337 or go online, become a new patient at Stages of Life Medical Institute.com. We're going to take a quick break, support our sponsors. Won't you, like Pharmacy Specialists in Maitland.
Good folks.
Compounding pharmacy that Dr. Dave has worked with for decades. We'll be right back. Yeah, I got everybody mentioned. Yeah, this computer just took a crap right in the middle of everything.
I hate when that happens.
I do too, I must say. It was like, just stalled. I thought, okay, well, maybe, and nope, Maybe it's...
Is that avatar of you or of your next door neighbor?
That's me. It was early in Avatar Land.
Oh, yeah.
Yeah, very early.
Gotcha.
Rather early in Avatar Land. He's making fun of my avatar, people. And that's okay.
Somebody has to.
Face is a little too fat.
No, I don't think so. I think it's interesting.
Yeah.
Got the hair color right, though.
Yeah, sort of, yeah. Everything. Eye color's wrong. All right, so I don't know if we have any questions on the web because our web computer crapped out here, but now it's back, and we shall now rejoin our regularly scheduled program, already in progress.
Ooh, I like that.
Or not. It might load, it might not. But I did have that one on the text line. That was it, the chronic one. But you got a text back, man. What are tiny centipede like tiny worms? Tiny centipede like tiny worms on the pavement in early morning here in the villages. Are they harmful? You have your glasses
Well, that's what's
on?
left of the person that lived in your house before you moved
right?
in.
I was going to say, are you... are your glasses working? Could be something else.
Need a little top up on that alcohol.
So
Those
right,
bags.
Time was 13, 12. So close. So, any Thanksgiving holiday? You know, do you ever find that in order to have a day or two off, you have to work extra hard before
Every year
and then after as well?
Every year I've been in practice. You know, there's hell to pay for taking a day off.
It really is.
Must be nice for you to take a day off. I'm thinking I work
There's no
7
day
days a
off.
week.
There's really no day off. I mean, even if you do
Was it?
actually get the day off, there's still
You still have paperwork to
annoyances.
do. You
Yeah.
still have all that the computer programming you have to do.
Yeah. Wait, is it working now?
Let's see.
Oh gosh. Come on, computer. Oh, there's the mouse.
Now
We're
you-
in business. Let's see.
Now, if this were a Tesla car, you'd be on the side of the road right now.
You might be right about that. Yeah. Swoosh. Listen to that fuzz. Here we go. Come on. Come on, baby. Yeah. Oh, there it is. Chronic pain.
Oh,
Knee.
excellent.
Look at all these people watching us wondering what the heck are we doing?
Yeah, we're trying to get back on the air is what we're doing.
We're on the air.
Oh, good.
We've always been on the air. I mean, it's just that we're just trying to fix the little things.
That's the beauty in live radio, by the way.
It is.
It's talk radio without a net.
It is. Here we go.
All right.
Yep. That worked.
It wasn't even a lightning strike.
Oh, Johnny Gill, everybody. Welcome back, Stages of Life Radio. What do you bring into the Thanksgiving celebration? Beer? Is that what's going on?
There you go.
Yeah. A lot of people bummed about the Rittenhouse verdict.
Well, they didn't find him guilty, did
No,
they?
they did not.
Oh, then why are they upset?
Well, some folks think that just gives the Whitey the opportunity to just do whatever Whitey wants.
Is that right?
I don't know.
After all, he shot and killed 2 black guys?
No.
Oh, another white. That's right. I forgot about that. Were they chasing him down, trying to beat him up? Nah, they were just trying to give him a pat on the back.
Good, you goofy people. All right, so welcome back to Stages of Life Radio. How ya doing? Stages of Life.
All
right. And we were talking about pain and this chronic. You know what? I'm going to assume
We're going to come back to that.
the chronic knee pain. Let's
Yeah.
go just to pain in general. We've talked about what pain is, what pain isn't, but.
Well, this is actually a good lead-in. Okay, so we have somebody that's asking us, well, I have chronic pain in my right knee, burning just above the kneecap. Now, I can about guarantee you that this person has been seen by orthopedic surgery once, twice, thrice.
Maybe got a couple of shots.
Couple of operations on this thing and has persistent pain. And the problem here is exactly what I'm trying to discuss with regards to other less specific problems.
Okay.
Now, what this person doesn't know, I'm going to assume that he or she has had at least one surgery to the knee, for which you're knocked out. You are knocked silly. And I earned a really good living knocking people out, keeping them alive while they were having this done. But what you don't know, is that in order to keep the field bloodless so that the surgeon can see what they need to see, they put a tourniquet, it's actually a double tourniquet, on your thigh. And they inflate it to 400 millimeters of mercury. Now, if you've ever had a blood pressure cuff put on that's inflated to 180 or 190, it hurts. So now we're going to go ahead and we're going to put one on your thigh and inflate it to 400, which is essentially going to keep blood from going into the knee as they operate on it. But just underneath that cuff, the distal cuff, the one that's just next to your knee, that edge lies right over what's called Hunter's Canal, and that's where the saphenous nerve passes through. So you can end up with chronic knee pain, not from the surgery or the trauma that led up to it, but from the compression postoperatively from the tourniquet. So the most likely possibility with your kneecap burning in that area is going to be post-surgical or tourniquet pain. Now, if you didn't have a tourniquet causing it, it would have been some other bit of trauma to that middle part of your thigh, nailing that saphenous nerve. So the treatment is very different. You don't need to stick with a needle. I used to poke needles in lots and lots of people. I've done that way too many times, and I'm not happy about it. Okay, and I'll explain why in just a second. But you can actually treat this with transdermal anti-convulsants. Okay, and it's something you'll know that's going to work in about 2 minutes. So you come in, we look you over, and go, bingo, this is what it's going to be. You put the goo on, and then you tell jokes for 2 minutes, and then all of a sudden the pain goes away. And it's kind of like, you feel like a Sunday morning preacher when that happens.
Nice.
So why is it? Okay, why do I hold needle jocks? These are the pain guys that stick needles in everybody. Why do I hold these folks with less than 100% admiration, sometimes known as disdain? And the answer is because so many of them are poking folks with steroids and never paying any attention as to what the consequences are. Mm-hmm. The consequences of injecting people with steroids are very interesting. First, it shuts down your adrenals, your adrenal glands, and that will compromise your immune system. Now, you think that's a good idea in the middle of a pandemic? All right? It's not a good time ever.
No.
But if you don't measure cortisol and ACTH levels, you're never going to know that this is happening. And it's particularly bad if they're receiving opiates, because they too will shut down the adrenal glands. So at stages, one of the things that we do routinely is we measure cortisol, we measure DHEA, and ACTH. Why do we do that? Because if you're using opiates, you have got to treat the adrenal suppression. Now, what other specialties have to do this that don't typically? Number one would be pulmonology, where they start giving people asthma medications in the form of inhalers, which further suppress the adrenal glands, and yet nobody really pays any attention to it.
Got the question up there, right?
Which question is that, the knee?
What do you think about albuterol breathalyzer
Well,
for COPD?
albuterol is fine. It's a beta blocker. It's actually the things like Brio and Advair and whatnot that cause the issue. So the steroidal ones are the problems because they shut down the adrenals. So you're giving somebody what's called a xenohormone. It's a hormone that's not found in nature, not found in human physiology, and it has all manners of things that you would call side effects, and I call them disasters.
Oh.
So opiates, injections, and inhalational steroids all have the same net effect. So if you think for a moment that I'm going to leave the psychiatrist wrong, you would be incorrect, because they do it with Adderall and Ritalin. Those will shut down the same adrenal glands.
Gosh.
Now, who cares about the adrenal glands? You know, when I was in medical school, we learned where they were, kind of what they secreted, and then after that they were promptly forgotten. Why? Because pathology of the adrenal glands is actually fairly uncommon, especially if you don't look for it. Okay, so the joke is I look for it, and it's shockingly common. Why? Because by the time people come to me, they've had plenty of opportunities to get messed up. I don't understand why I wake up at 3 o'clock in the morning and I can't get back to bed. Hallmark. That's the hallmark of this, right?
Oh, I thought you were saying Hallmark movies.
This is the hallmark of it. No, Hallmark. If they don't put you to sleep, nothing will.
Nantucket Noel this year.
Oh, really? Mm-hmm. Oh, good. Oh, okay, I can see how that'll turn out. Yeah, I can imagine what the limericks will sound like.
What do you think? It's a high school girl who left the island and then came back and met up with her high school boyfriend. And, well, you know. Isn't that the premise of every Hallmark holiday
now they have a
movie?
whole house full of little elves. Right. So, so the upshot of it is that there's so many things that you have to do when you're treating somebody for pain that doesn't involve or doesn't necessarily solely and exclusively involve using pain medications.
Well, shouldn't
You've got to know what the heck you're...
anti-inflammatories anyway
well,
for most
they're
of
called
this?
adjuncts. Okay, so let's understand. So if you have dental pain, what's the most effective medication for dental pain? And it's actually a non-steroidal anti-inflammatory. Mm-hmm. What about bursitis? What about neuritis? Neuropathy?
Right?
No, anticonvulsants.
Okay.
So these things are called adjuvant or additional medications or helpers. You can call it opiate helper, hamburger helper if you choose. But these are very, very important in the treatment of pain. Things like depression follow pain. Why? Okay, because, I guess I'd be depressed if I heard all the time. No, you're depressed if you have kids that keep you from sleeping at night. And the joke is pain will keep you from sleeping. You get depressed for the same reason. So the first thing that I typically do when somebody comes in with chronic pain problems is I give them something to help them sleep. Why does that make any difference? Because you can handle things a lot better after you start getting into a normal sleep cycle. Exactly. So that's about 50 to 60% of the patients that come in with pain problems of all sorts, that they've been screwed up either through their own misdeeds, like the blue screens that people like to look at night, television sets and whatnot, the drinking alcohol at night. There are a lot of things that you can do to mess up your sleep, but the medications are almost a given. So these things have got to be addressed and taken care of to be treated for pain properly. Okay, now, why would I come off my high horse and think I'm the only one that knows how to do this? Well, for 60,000 patients in 42 years, I've seen a couple patterns over the years, wouldn't you think? So this is pretty much the way that this is going to work. So steroids, opiates, amphetamines, those are the things that typically goof up sleep cycles and goof up your adrenals. So what I was taught about the adrenal glands when I was in medical school was they kick out 150 different hormones, and if you get tuberculosis or cancer down there, it can be a real problem. Well, great. Okay, TB of the adrenal glands is something I've never seen, and cancer of the adrenals is extraordinarily rare, and yet hypoadrenalism is remarkably common. Remarkably common. So how do we go about figuring this out? It's all a matter of blood work. You need to look at patients rather from standing back. If you look at your patient and the first thing you do is you start looking at their ear because they have ear pain, you're going to miss everything. If you look at an x-ray by getting up with a magnifying glass and putting it up against a light bulb and really look at the small details, you'll miss everything. The first view of an x-ray needs to be from across the room. The first view of your patient needs to be from across the room or across a table, because you can learn a lot just by watching the way they move and go about their business. Got to be done. It's very, very important to see somebody that's trained in this. Now, the medications, are guaranteed to mess people up. Just the way these things work. But then there are medications that you can take that are quite natural that will mess you up as well. So don't believe for a minute that just because something's a prescription that it's dangerous or bad for you. And just because something is natural, well, then it means it's good for you and safe, because it couldn't be further from the truth. So again, what we need to do is we need to get a good, fair history of what's going on with the patients and then start peeling back the problem like an onion until you see what's underneath of it. Or stripping paint off an old piece of furniture. I stopped using that, especially with women, because they get mad at me.
Yeah, people don't
they
like
go,
that.
That's just kind of
It's
a bad
kind of a
visual.
weird, innuendo. So, are we learning about pain or what? We're also taking your phone calls here, 407-422-1212. Or you can text in at 23680. Oh, these guys are so loud. Here we go. Put them in the other room. All right. We'll be right back. You're listening to News Radio WFLA Orlando 93.1, 94.1, and 540 AM, and of course on the iHeart Radio app. iHeart Podcast available, and as you know, we are live on Facebook and just about every social media available. Stay right there. It's a true story. I mean, it is true. We are. I mean, on everything. What we got here? So, Sabrina, suggestion for right foot pain. Almost 2 years. Pain in between big toe and second. Across the foot to the outer side. MRI shows bone contusion edema in the mid portion, the vascular dorsal, epicenter gesticular to medial cuneiform, base of the third metatarsal.
Just move forward to shows good. No fluid, no fracture, no synovitis, ligament or tendon issues. Okay. What that is most likely is going to be neuralgia of something called the deep perineal nerve. So this is Sabrina. Now, Sabrina, first thing you want to do is to research perineal, that's spelled Peroneal nerve. And there are two branches of the perineal nerve as it comes off the sciatic, but what you're looking for is what happens to it when it gets into the ankle. So it can be damaged in two places, but the most common is actually in the dorsum of the foot, and that's most likely what's happening with you. So either it entrapped it just between the toes, which is the most likely, and that's where the deep perineal nerve emerges through the retinaculum, or it could be up a little bit further in the ankle at something called the extensor retinaculum. So get a look at an anatomy textbook, extensor retinaculum, and then look for the deep perineal nerve. And I think you're going to start seeing some interesting things. In particular, if you start looking for perineal nerve referred pain, and that's from things happening further up the back in the hip. So I think what you've got is a foot problem there that's probably a result of either an ankle injury, okay, at the extensor retinaculum, or it could be along the dorsum of the foot. The problem with these sorts of issues is that you're going to see all manners of scratches, dents, and dings, just as if you were a used car, because you kind of are, right? So if you go buy a used car, you're going to find all sorts of dings and dents, but it doesn't necessarily mean that the car is going to run poorly.
What about the boot on, the cast, the boot, and all the special shoes?
May not have been necessary.
Stuff. I think it's...
that warrants getting a look at, because that's actually, you'd know that in 5 or 6 minutes. That's not a complicated endeavor. It sounds like it would be, but it's not.
Sabrina, it sounds like you need a
That's
second
one.
or third opinion.
Yeah,
there.
I'd say that would probably be a good place to start. Yeah.
Most definitely. I'm sorry that you're going through this kind of deal. Who do I see for this? The podiatrist is not helpful.
Well, that's what I do for a living. Okay.
Well, you might want to come and see the doc.
that would be the kind of that would be the message there. Unless you can find somebody else.
That was my takeaway. Yeah. Stages of Life Medical Institute.com, Sabrina. If you're on our page now, you must know that. So
yeah.
And if you're on my page, go over to Stages of Life Medical Institute and like the page and follow along. Okay.
Which kind of leads me to something interesting.
Welcome back to Stages of Life Radio. Hello there. Hope you are having a good Sunday. Did you hear Dan Mullins got fired? Coach of the Florida Gators. Yeah, it was a quick fall. Anyway, just keeping you up on the news. Oh, it looks like all booster shots have been approved,
No
too.
kidding. Oh, imagine that. And even the Johnson & Johnson at 2 months.
Yes. And with that in mind, I believe
What does that tell you?
Got one of our favorite callers. Hang on a sec here. There it is. All right. Rick from Altamont Springs. How you doing, buddy?
Hello?
Hey.
Why, hello.
Oh, it's hard to hear you.
Okay.
I had my second Johnson shot today.
You had your second one? What
I
the
wanted to know
Yeah, go on.
how long will I have immunity? What is the effect of this? I've gotten no reaction twice except a sore arm.
Right.
And
Okay.
What is the percentage of effectiveness and how long is
Okay, Rick, here's I want you to do your own thinking on this one. For the Moderna and the Pfizer, which were actually 97% effective, and the J&J being in the 60s, what they found was that people will maintain immunity for the J&J for about 2 months. Moderna and Pfizer, 6. So when do you think you're going to need the next Johnson & Johnson shot? About 2 months. Yeah. So I've not recommended the J&J shots since they came out because they're not effective and they're not going to give people the right kind of immunity. So I think you picked the wrong type of injection.
Again, we said from the get-go with the J&J that it was for the lazy, for the people that were like,
I only want one.
I'll just get the one. I don't want to go back and get a booster or whatever. And
so what they're saying is that if you had the Johnson & Johnson, 2 months is all you're going to get at it.
Yeah.
And that's probably what's going to happen in the future because past is prologue.
407-422-1212, going to get in before the end of the show.
Yeah. So what I wanted to do is we had somebody who called in about, on the media, social media stuff, about some foot pain. Couldn't figure out what's wrong with it, going through all kinds of very interesting but conservative therapy, couldn't get it repaired. Mm-hmm. This, by definition, is called cryptogenic pain.
Okay.
Or pain of uncertain or undiagnosed
Unknown origin.
etiology. Correct. So if you can't figure out what's wrong, you don't have a prayer to fix it. That's the key to this. So the trick is to find somebody that has seen that before. That is the key. And so that's not always an easy thing to do. Have I seen that one before? Yeah. Oh, yeah. So finding somebody to deal with that, is going to get interesting. Find a specialist in cryptogenic pain.
Okay. Got
Diagnostician.
A big old compliment on the text line, 23680, if you want to toss some compliments. This one says, I want to compliment you on today's broadcast.
Cool.
As a clinical specialist who spent 20 years in pain management, the most important thing that you stressed was looking beyond the obvious pain symptoms. So few doctors do this. Excellent presentation.
Well, thank you. So as a clinician, you would have gotten a kick out of one that I had this week.
Ooh, share.
Yeah, a gal comes in and she's afraid that she has an aneurysm of the brain because her mother died of it. Her mother was a smoker, hypertensive, didn't take care of herself. This lady takes care of herself.
It doesn't mean
and
anything
yet she
with
has
aneurysm.
a terrible headache. So she wants to get treated for this, that, or the other. But nevertheless, she has pain in the left ear, left jaw, and numbness that comes and goes up the side of the head. Feels like her head's inside of a bucket, and she feels bad, right? Yeah. Okay, so she's seen a bunch of different people. They looked in her ear, nothing going on there, nothing here, nothing there, nothing in the sinuses as they looked at them. Exquisite pain with palpation and percussion over the mastoid sinus. Now, the mastoid sinus, okay, now 20 years as a pain clinician, you're just a beginner, okay? Back in the day, we used to actually do mastoidectomies. Why? Because mastoid sinusitis is a bear, okay? And it hasn't gone away. So you've got to look for mastoid sinusitis, and it typically makes people feel like their head's inside of a bucket. But so she's going to end up getting her head taken care of that way. But it's kind of interesting. So there are things that are out there that you have to look for. What do you do about somebody that comes in with right hemifacial pain? That means pain on one side of your head. You come, well, it looks like you're having some kind of stroke. I had one of these came in, but she was told that she had thalamic pain syndrome, because that's what the guys at the university thought it might be. These are beginners that didn't really or haven't had any experience with pain. What they didn't do is look at her. They didn't look at the patient, apparently.
Oh,
so from sitting off at 4 feet, you could look at her and know that the left side of her face was swollen. Looked a little bit like a chipmunk. Okay, now any moms out there know what that might be? So if your kid comes home from daycare, the kid comes home from daycare and then they look like little chipmunks, that's mumps. Okay? Adults with mumps, yes, so you only maintain immunity for about 10 years. So these things have to be considered by the pain doc as well as everybody else. So if you're going to be in this business, you'd had best understand that your first responsibility is not to go look for a needle to inject somebody or to write a prescription for opiates. It's to figure out what's wrong with them.
And God, good luck to chiropractors. They do what they do, but you really need to figure out why it's going on.
You have to figure out why. Mm-hmm. And if you can figure out why, you can only then figure out the what. What does it take to fix it? Well,
exactly.
What's your favorite medication for this? Yeah, it's called my brain.
Before we go, we got another question. Person of mine must have checked in after we started the show, but magic minerals is becoming a big issue.
Yeah, it's because I've got about 10,000 patients on it.
Stages of life vitamins, and right now I'm having problems getting that stopped.
Yeah, okay. Well, our major manufacturer for this, okay, has been, what's the word I'm looking for? Jerking me around for about 3.5 months. Now, we order typically 6-7 months ahead, right? So we don't run out. Yeah. This guy, nah. It'll be out on Monday. We have the pallets all ready to go, which have been lies all the way along. So they continue to lie to us. So what I'm doing is I'm moving people over down to basics, which gives you about 80% of the mineral mix. Mm-hmm. All right. And, so when you come back and when we get the magic minerals back, we just simply swap it out. Okay. So, until then, use down to basics without iron.
Yeah.
Very important. Down to basics without iron. That iron is for young, heavily menstruating females. All right, you don't want to make yourself constipated. So I have people come and say, well, it's the same price. I'd rather get the iron because it's a freebie. I'm thinking, no. If you have enough iron, that's enough.
Yeah, you'll be good. Yeah, you don't want to be setting off things.
No, it's bad. Okay, yeah. So the one thing that you'll learn about pain medications is that it's very, very easy, okay, to make people, quote unquote, feel a little bit better, but it always comes at a cost. And you need to understand what those costs are. All pain medications will cause insomnia. All pain medications will cause constipation. So the trick, okay, to this whole deal is to make sure that you don't. So how do you treat somebody for insomnia? Okay, what do? Do you use a benzodiazepine for it? Probably not. Why? Because they don't work longer than 3 to 6 weeks, and then you've got somebody addicted to a benzo. So what else are you going to use? GABA agonist? Sometimes it works. My personal favorite for most of these things is mirtazapine, okay, because it doesn't have any drag to it, and it knocks everybody out. And as an anesthesiologist, I'd like to think I can knock anybody out.
More information on any products referenced here, with the exception of Magic Minerals.
Yeah, there you go.
Go to stagesoflifevitamins.com. And for any more information on Stages of Life, go to stagesoflifemedicalinstitute.com. Y'all have yourselves a safe week. Happy Thanksgiving.
And happy Thanksgiving to you and everybody in our listening audience.
All right. We'll see you later. Be well.
You've been listening to Stages of Life Radio with Dr. David Klein. Check out stagesoflifemedicalinstitute.com or stop by 1917 Booth Circle in Longwood near the intersection of I-4 and 434. Call 407-679-3337. That's 407-679-3337. Dr. Klein accepts many insurances and Medicare too. Join us next Sunday at 4 p.m. on News Radio WFLA Orlando.